Hello guys, with you Dr. Muhammad Hamid, an ECVMG certified physician, and today we are going to talk about the pharmacology chapter for the USMLE Step 1 exam from the first aid. This is the pharmacology chapter, and the first topic is like enzyme kinetics. There is some terms you have to know, like Michaelis-Menten kinetics and Lineweaver-Burke plot. Actually, like Michaelis-Menten kinetics and Lineweaver-Burke plot are actually the same, and Lineweaver-Burke plot is the reciprocal of Michaelis-Menten kinetics. This is like a relationship of velocity. Michaelis-Menten kinetics is a relationship for velocity on the y-axis, and S on the x-axis. So S is a substrate. S stands for the substrate. So first we will start by talking about some terms like Km. So Km is like the substrate concentration, which is needed to for an enzyme to reach a rate of half the Vmax. So on the s-axis is x-axis is like the S, which is the substrate, and this is like the Km. So the Km is how much substrates do I need to reach like Vmax. So this is the Km here, and it relates to like a half of the Vmax. It's again, it is the substrate concentration, the concentration of the substrates, which needed for an enzyme to reach the half of the Vmax, which is half of the maximum velocity. And it is inversely related to the affinity of the enzyme for its substrate. So if the affinity of the enzyme for its substrate is high, there is high affinity, there is a Km is gonna be like lower, it's gonna be decreased. And on the other hand, if the affinity of the enzyme for its substrate is not so good, the Km is gonna go on the opposite direction and increase. Most enzymatic reaction follows like a hyperbolic curve, which is like Michaelis-Menten kinetics that we this is like the curve, hyperbolic curve. But you have to watch for some enzymatic reactions that exhibit like a sigmoid curve. Very famous example for that is like hemoglobin. So hemoglobin exhibits like a sigmoid curve, which is not a unique curve like this, which is uh, and yeah, this curve has like the same direction, but the S-shaped curve has like two directions, so different kind of relationship at different condition. What this means is that as a hemoglobin attaches like more oxygen, the affinity for the oxygen increases by um, binding more oxygen. So as you bind more oxygen, your the affinity is gonna increase, so you'll have like S-shaped or sigmoid curve, in contrast with this curve, which is hyperbolic curve. There is this here the you gonna we're gonna explain to you like the different kind of inhibitor, like there is for a drug or a substrate, like there is a competitive inhibitor, that means aka reversible inhibitor, and the non-competitive inhibitor. This is the Vmax. The Vmax, it is the maximum velocity that gonna be reached. So after this, like the curve is gonna be flat. And with non-competitive inhibitor, the non-competitive inhibitor is gonna affect the Vmax. You will not be able in any way to reach the Vmax. So it's a curve, it goes up and it plateaus here. This is like a plateau with non-competitive inhibitor versus a competitive inhibitor. It is gonna affect the curve. But it is gonna reach the Vmax also. It's gonna reach the Vmax, but just at a later substance or substrate concentration. So higher substrate concentration is needed for you to reach like the Vmax. This is the effect of the competitive inhibitor. Essentially, you need more substrate to reach the Vmax, but you at the end you're gonna reach the Vmax with competitive inhibitor, reversible competitive inhibitor, and but non-competitive inhibitor you can't reach the Vmax, and to complete the line Weaver Berke plot, you have to go fastest through that. I will tell you some key point, but the math you don't need to know the math behind that. So it is the same as the above. Michaelis Menten kinetic, but instead of Km, it's 1 over negative Km, 1 over negative V max, and the slope. So it is like the equation here, and is divided by 1. So there is a velocity which is plotted against the substrate. Here's the 1 over the velocity is plotted over 1 over the substrate. And the two important things you have to know is like the interception and the line intercept, like the y-axis here is which correlates like 1 over the Vmax, and the intercept is like x-axis on the negative side, which correlates with like 1 over negative km. So two key important points you have to know, like the closer to 0 on the y-axis, this means like higher V max. So this is the line here, and if you compare it with this line, which is closer to y0, this line is has a higher V max. So on the x-axis, the same with the x-axis. So for this x-axis, you are the closer to x to 0. So here you are here closer to 0 compared to this. So you will have like higher km. So the closer to 0 on the y-axis, you will have just a higher Vmax, and the closer to 0 on the x-axis, you are gonna get a higher km. So and I'm gonna go say the same things that I have just said, but through this table. So you have you have competitive inhibitors and the non-competitive inhibitor. The competitive inhibitor are further subdivided into reversible competitive inhibitor and irreversible competitive inhibitor, and the non-competitive inhibitor are on the other side. So first, you're gonna compare them by resemblance to the substrate. The competitive inhibitor, whether reversible or irreversible, of course, they have to be resemblant to resemblance to the substrate, has resemblance to the substrate because they gonna compete with it. So versus the non-competitive inhibitors, they will not have no resemblance to the substrate, and overcome by increased substrate. So the competitive inhibitor are competing with it, and the reversible ones. And if you increase the substrate, you will gonna get, as we have just said, the same velocity, but at a higher substrate concentration versus the irreversible competitive inhibitor and the non-competitive inhibitor. Both of them, even if you increase the substrate, you're not gonna reach the Vmax. So if you increase the substrate, you will not gonna reach the Vmax. So and for binding for the active site, so the competitive inhibitor is a reversible or irreversible. They are competitive, so they have to bind on the active side. But the non-competitive inhibitor, they don't bind to the active site. They bind just to an allosteric site, different site from the uh, uh, enzymes. So effect on the Vmax, as we have just said, the competitive inhibitor there is no change in Vmax. It's gonna be reached, but at a higher substrate, as we have just said. But non-competitive inhibitor, reversible competitive inhibitor and non-competitive inhibitor, the Vmax is gonna be decreased. So the Vmax is gonna be decreased. Effect on the game, on the other hand, there will be no change on the for the competitive inhibitor, which are irreversible competitive inhibitor and non-competitive inhibitor. But the reversible competitive inhibitor, the Km is gonna be increased, as we have just said. That means like more substrate needed. So, and for the pharmacodynamics, there are two terms, which is like potency and efficacy, and essentially, potency is just means how much the drugs they are gonna need to produce an effect. So competitive inhibitor, which are reversible, decrease potency. That means you have need more substrate or more amount to reach the Vmax. So this means a decrease in the potency, which it translates like increase in the Km. The Km actually means decrease in the potency. Km decrease the amount to decrease the amount of the substrate to get like half Vmax increase. This means decrease in potency. And on the other hand, the competitive irreversible inhibitors and the non-competitive inhibitors, they both gonna decrease the efficacy, aka they gonna decrease the Vmax. So this the Vmax is decreased here and it's decreased here. The efficacy is the maximum effect. So this you are not going to get the maximum effect in non-competitive inhibitor and the competitive irreversible inhibitors. So don't memorize that, just understand it, and the exam is MCQ at the end. Just understand it and don't try to memorize it. So pharmacokinetics, our next topic is pharmacokinetics. So a lot of terms. First is a bioavailability. The abbreviation for it is F. So it is like the fraction of the administered drug reaching the systemic circulation, and consequently for an IV dose is logically to be 100%. You are injecting the drug directly into the circulation, so the F will be 100%, and the fraction reaching the systemic circulation is 100%. As but this typically is going to be less than 100% for oral drugs, because you have absorption, and some drugs is going to be lost uh, as absorption, and also as a first pass metabolism. And you can calculate it from the area under the curve. So area under the curve here are plotting like plasma concentration on the y-axis and the time on the x-axis. And the time goes, the plasma concentration is gonna be different for IV versus oral. So first we can start by oral. As the time goes, the absorption of the drug for the oral drugs is gonna increase its concentration, and till it reaches like the maximum concentration, and then it gonna go down over time. So this is like the area under the curve for oral drugs versus the area under the curve for IV drugs. So if you notice here, the plasma concentration of the drug is gonna be at the maximum from the time zero. So it's like time zero, and the plasma concentration is gonna be at the maximum. You're injecting blood directly into the circulation, and the over time is gonna decrease till it reaches the zero. So this is like a formula. You will not get so much by memorizing it, but if you need like area, the bioavailability is gonna be area under the curve for the oral over area under the curve for IV, and for the dose you're gonna like make the reciprocal of that. So area under the curve over times the dose IV. So this is oral, this is gonna be IV, and this or IV, this is gonna be oral. To memorize it, you have to know that area under the curve oral is above. So consequently, area under the curve IV is gonna be below. So, and the dose is like the reciprocal of this. Just memorize one stuff, which is area under the curve oral is above. So this is for bioavailability. So the next term is like volume of distribution. So this is like a theoretical value which relates like the drug amount to the plasma concentration, the relationship between drug amount to plasma concentration. As a drug is not gonna stay in the circulation, is gonna be distributed into the extracellular fluid and the all tissue, and this is gonna be affecting its plasma concentration, because it will go into the tissue at the expense of staying in like the circulation. So the plasma concentration is gonna be different for different kind of drugs. So this is volume of the distribution. And the liver of the kidney disease, of course, increase volume of distribution. Why is that? Because like decrease protein binding. So decrease protein binding, they gonna make like the drug be able to go anywhere. Liver and the kidneys are like the manufacturing proteins, and like kidney, when you have kidney disease, like you have microalbuminuria, and the protein is gonna go into the urine. So decreased protein is gonna decrease protein binding, and consequently more drug is gonna be like liberal to move around and go into the extracellular fluid and the older tissues. So The drugs may distribute in more than one compartment consequently, and like hemodialysis is most effective for drugs with low volume of distribution. So logically, if you have a drug with low volume of distribution, it means this is like most of it is staying intravascular, and so if you like do hemodialysis like for the intravascular blood, or and the drug is in it, which is in it, so it would be very effective versus if we do hemodialysis, for example, for a drug which is not there in the intravascular compartment, which is in the extracellular fluid, or in all like the tissue like fat, so it's not gonna be very effective for a drug with high volume of distribution. So this is like the table. There are like low volume of distribution, medium, and high volume of distribution. So by low volume of distribution, we just mean like intravascular. Medium volume of distribution means like it is intravascular plus extracellular fluid. But by high volume of distribution, we mean the drug just distributes in all the tissues, including the fat. So there is like a drug types or criteria for different drugs to be categorized, and they go for the different kind of volume of distribution. So for the drug to have low volume of distribution, it just means it contains intravascularly. It has to be a large charged molecule, which will not be able just to pass through the vessels and go extracellular fluid to the extracellular fluid, or it may be plasma protein bounding. So the plasma proteins are just capturing it in the circulation, either plasma protein bounded or large charged molecule. And for the medium volume of distribution category, this includes like the small hydrophilic molecules. Just to be aware, like hydrophilic, not lipophilic, hydrophilic. So it is, and small. Being small, it can go into the extracellular fluid, but hydrophilicity, it will not allow it to just to go into the fat. For example, it's gonna be staying into the extracellular fluid versus the highly distributed substances, and this go will gonna go is gonna go are gonna go to all tissues, including the fats. This will include like small lipophilic molecules, especially if like bound to tissue proteins. So this is a formula for volume of distribution. So the volume of distribution equals like amount of the drug of the body times by plasma drug concentration. So plasma drug concentration is down, and volume of distribution is above. So if it is have a high, logically, if a drug have a high volume of distribution, it will have has like low plasma drug concentration because it is distributed in the fat and anywhere inside the body. So the plasma drug concentration is gonna be low, and if a drug has like a high volume of distribution, the amount of the drug of the body is like gonna be increased. So it is like directly related to the amount of the drug of the body and inversely related to the plasma drug concentration. So the plasma drug concentration is inversely relationship in with its volume of distribution. So the volume of distribution increases, more of the blood will not stay in the plasma, and the plasma drug concentration is gonna decrease. And the next term is clearance. So to be fast, it's like the volume of the plasma cleared from the drug per unit of the time. So it's like how much plasma is cleared from the drug every unit of the time. So it's maybe impaired on the defects of cardiac, hepatic, renal function. As we know, these groups of patients, they may not like clear drugs well, and we have like to calculate modified doses for them depending on the way of elimination for each drug and the clearance. Also, if it is increased, the plasma drug concentration will go down, of course, inverse relationship, and it's related to directly related to the rate of elimination of the drug. In other words, like equals aka volume of distribution times elimination constant. How so to calculate the clearance, how much the blood is distributed different kind of the body times like elimination constant for each group. Next very high yield topic is like terms like high half-life. So the half-life very famously known for it's like T half life it's T half, so that is like the time required to eliminate half of the drug from the body. So you will start like by the drug entering into your body. You got like IV dose of 100 milligrams, and the half-life is like a time. So you are speaking about a time. How much time does it take for this 100 milligrams to just reach to 50 milligrams, and then to 25, then to 12.5 to 6.25. So it is like how the time. So this is the half-life. And this is a very important concept is the steady state. So this, I think it's very hard to understand it, but you imagine it like you are given someone a drug orally, and the patient is starting to absorb it through the intestine, and takes time. Some of the drug is still in the intestine, some of it is in the circulation, and it is at the same time it is being excreted. So while some of it is still in like in the intestine, some of it of the drug is being in the circulation and being excreted, so it's like in and out, as you know. So you will not get like effective drug concentration from the first dose. So it is like you imagine it like a movie going on. So uh, as you give more doses, some of the previous dose stays in the circulation, not all of it, as we said, like there's like half time, and some stays and some goes, and this goes like exponentially, like. So and by each dose, some of the drug stays and accumulates with the next dose. And this is like you have to know this number very well. It is very high to know, like for the drugs with a first order kinesis. So we're gonna talk about it further as we proceed. Takes like 4 to 5 half lives to reach like a steady state. So, and to reach like 90%, it will take like 3.3 half-life. Memorize these numbers very well. So 4 to 5 half-lives to reach a steady state, 3.3 half-lives to reach like 90% of the steady state. So this is the T half. This is the equation of zero point 0.7 times volume of distribution divided by the clearance. But this is for the first order elimination. And those are calculation. So this is the idea for the steady states. Brings like the loading dose. Some drugs I will not wait like 4 to 5 half-lives to reach a steady state. For example, levetiracetam, the patient is convulsing, for example, and I have to give him like a loading dose to control the seizures. So this will depend on the CB, which is the target plasma concentration, how much drugs that do I need for to reach, and the volume of distribution, which is specific for each drug, and the bioavailability. For IV, it's 100%, or it would be different for different kind of drugs. So how much the drug that do I need, times like the volume of distribution of the drug and divided by the bioavailability. And the maintenance dose is like different. We had like the tau, which is like dosage interval between the doses. So the maintenance dose, if I increase this like tau, increase the interval between the doses, I have to give higher maintenance dose to cover this increase the time. So as I increase the time, it's logically to increase the maintenance dose, like. So also it depends on the CB, which is the target plasma concentration. How much drug do I need to be effective in the circulation? If I need a higher CB, which is concentration in the plasma, if I, for example, need a higher concentration of the plasma of a specific drug, I have to give a higher maintenance dose. Also, I have to give a higher loading dose, so that it is like directly related, both of them, to the concentration in the plasma, and inversely related to the bioavailability, because the bioavailability is affecting like absorption and availability of the drug in the circulation. And there is like a third element is like the tau, which is like dosage interval between the doses. And if I will increase the time between the doses, I have to give like a higher maintenance dose. And in renal and liver disease, maintenance doses decreases. and the loading dose usually unchanged. So the dose that I will start with to like get the effectiveness that I need is not gonna be changed, but the maintenance doses will be decreased. That is very logical. I will decrease the maintenance dose because a less of the drug is secreted. So it's logical for me to decrease the maintenance dose, but you have to be careful that the loading dose is not gonna be changed in renal and liver disease. And the time to steady state depends primarily on the T half and is independent of dose and the dosing frequency. Also very high yield. So when you're gonna reach like a steady state that we talked about, it depends on the T half, which is different for different kind of drugs, and will not is not dependent the dosing or dosing frequency like the maintenance dose or the things that we talked about. And we're gonna go fast through, through like drug metabolism. So the drug can be metabolized either in phase one, so this is like phase one here, and or the phase two reaction. So phase one reactions are predominantly like cytochrome B450 dependent, and you have to memorize it. It includes like reduction, oxidation, and hydrolysis. So it's like cytochrome B450 dependent, and the reduction, oxidation, hydrolysis. This is like phase one, and the phase two. So it's like it contains methylation, glucuronidation, and acetylation, also sulfation, adding all these of kind of groups. So these reactions like serve to bioactivate or deactivate substance. So some of the drugs, like actually just go through the drug metabolism to be activated. It has to be metabolized to be activated, and the others and or most drugs just deactivated or like deactivated by this drug metabolism. So some drugs are activated bioactivated, some deactivated by this, but and all of this does not have to be like sequential. Phase one doesn't need to be happen first because it has one in its name. Phase two may happen first, or phase one may not even happen. So there's no need like to be sequential. So phase one can follow phase two or just take place as a single reaction, no phase two, whatever. So very high yield to know that the geriatric patient lose phase one first. So the phase one of reduction, oxidation, and hydrolysis is just gonna be affected first in like geriatric patients. And another NB is like patient who are like slow acetylator have increased adverse events from certain drugs because of decrease. So this acetylation is part of from the phase two. Some this would be very important for drugs, for example, isoniazide. So if you have like if you are like slow acetylator, the metabolism of isoniazide, which is dependent on acetylation, is gonna be affected. So just know that. And the phase one like products like slightly polar active or inactive, and but the phase two will produce very polar, which are like ready to be excreted, and hydrophilic metabolites, and it's gonna be excreted. So typically phase two products are very like very polar, while phase one produce slightly polar metabolized, and of course very polar metabolites are gonna be more readily excreted into the serum, urine, sweat, or like bile in the stool, depending on the specific drug mode of excretion. So very high yield topic, very high yield topic is like elimination of drugs. We're gonna concentrate on it on this topic. So elimination of the drugs is gonna be in two styles, either zero order elimination or first order elimination. So when we talk about like zero order elimination, so this means like rate of elimination just constant regardless of like CB, which is a concentration of the plasma. Just means if you put 100 grams of the drugs in the plasma, it is the same as 1 milligram. Whatever the amount of the drug that there is in the plasma, like there is a specific amount that can be excreted, you know. So it's like a specific amount that can be excreted because and so so let's look at this graph like plotting like the drug plasma concentration on the y-axis and the time on the x-axis is the same as this. So we will start by high drug plasma concentration. As the time goes, it will decrease. So the first so this is like the first T half, second T half, third T half. So if you like look at this graph, so the first T half it is larger than the second T half, which is larger than the third T half. Why does this occur? Like it is the time of the T half decreases as the concentration decreases, because we will start by a high volume. So there is like I need to decrease this high volume by the half. For example, I have like 100 milligram, and as we have said, like zero order elimination excretes only limited amount per time. For example, excretes like 5 milligrams per like hour. So I will need more hours to get rid of this half of this volume, because I was started with high volume, and of course this time will be more than the time needed to excrete like 25 milligrams. I started by 100 to reach 50. It is gonna be more than the time from 50 to 25, from 25 to 12.5. So as the time decreases, so the time decreases to get rid of the half of the concentration. So this is for the zero order elimination, and to read together is like the rate of elimination is constant regardless of the concentration of the plasma. Constant amount of the drug eliminated by unit of time. So the CB decreases like linearly with time. The concentration is gonna decrease linearly, so it's like the linear graph here. And example of the drugs, you have to like memorize these examples. Phenytoin is like in B, phenytoin, ethanol, and aspirin. So very famous drugs to have like zero order elimination. Phenytoin, ethanol, and but by zero order elimination, like the body has a specific capacity to get rid of phenytoin, antiepileptic, or ethanol, or aspirin, and it doesn't have like the capability to exceed that whatever happens. So phenytoin, ethanol, and aspirin all have zero order elimination, and it's like capacity limited elimination. So, but first order elimination, it is like the opposite. It is like the rate of the first order elimination is directly proportional to the drug concentration. So if you put more amount of the drug, the kidneys and the elimination is gonna work harder and get more amount. If you put less amount, you will remove less amount. So the rate of the first order elimination is directly proportional to the drug concentration, constant fraction of the drug eliminated by unit of the time, and it decreases exponentially with time. And most this is applied for most drugs, no specific so to have to know like the most drugs have like first order elimination, but zero order elimination you have to memorize phenytoin, ethanol, and aspirin. The first order elimination is like the time is constant, so the body accommodates to the whatever amount. So if you have like high amount, it's gonna excrete it faster and excrete higher amount also, so we'll get the same time. So it's like accommodating the first order eliminations. The body is accommodating to the whatever amount is in the body and getting rid of it. So the time is constant. Unlike like zero order elimination, where the body is like there's some constraints and some capacity limited elimination. So very high yield topic. This is less high yield. It's like topic is like urine pH and drug elimination, like the ionized species like trapped in the urine and cleared quickly, and the neutral forms can be reabsorbed. It is like an info you have to know that when you have like ionized stuff, it's gonna be trapped in urine and cleared quickly. So you have like weak acids and weak bases. For example, for weak acid like phenobarbital, methotrexate, phenobarbital, any convulsant, methotrexate, chemotherapeutic agent, and aspirin, salicylate, these are all like weak acids, and they are trapped in basic environment. So remember, the ionized species are trapped in urine and cleared quickly. So they are acids and trapped in basic environments, very logical. So if you have like overdose from aspirin or something, you have like to make the environment basic. What is the basic stuff, basic environment that we have, like sodium bicarbonate, which can alkalize the urine, and they make it like here's like this is the trapped form, and to get rid of phenobarbital, methotrexate, aspirin, three of them, they are all weak acids. You gonna give like sodium bicarb, which is alkaline, to give to make them trapped and ionized here. And the weak bases, on the other hand, you have to, three examples, like two examples, tricyclic antidepressant and amphetamines. They are like weak bases, and they are like trapped on the opposite acidic environment. So you will give like ammonium chloride to acidify the urine. So you have weak acids, sodium bicarbonate, a base to alkalinize the urine. Weak bases, ammonium chloride and acid to acidify the urine to make them like trapped. So this is the trapped form for them. On the other hand, this is the trapped form, which is the form you're gonna excrete it, and you will be able to more excrete this toxic stuff if you got like toxicity of this. So it's tricyclic antidepressant. The toxicity is initially treated with sodium bicarbonate, but the sodium bicarbonate for the tricyclic has like other rule is like to overcome the sodium channel blocking activity, like cardiotoxic. So you have first not like to give them something to stabilize that, which is sodium bicarbonate, the same as weak acids, but they have like different area of working. It's here's like to get rid of it through making them like trapped in the urine and so. But here you have like two steps. First is give to sodium bicarbonate. This will gonna overcome the sodium channel blocking to not to have like cardiotoxicity from tricyclic antidepressant. And after you do that, and this is gonna, of course, will not accelerate drug elimination. You're just overcoming the important thing is first. You will not be happy by eliminating the drug while you are having like cardiotoxicity. First, like stabilize your heart with sodium bicarbonate. If not, if it is not gonna accelerate the elimination, and then you for severe alkalosis, you may treat. With ammonium chloride to acidify the urine in order not as the experiment of like stabilizing the heart. You're gonna give also you want to get rid of that of the drug, for example. So and this is for like the the point about pH. So, efficacy versus potency. We talked about that earlier, but we're gonna stress over that efficacy versus potency. So, efficacy is like the maximum effect of the drugs which you can produce, which is like intrinsic activity. The drug is efficacious. The other drug is not efficacious, like intrinsic to the drug, and it is represented on the Y value by the Vmax. We talked about that. So this is if efficacious, like gonna by efficacious we mean like gonna produce the maximum effect. So this is if efficacy, and increase Y value. If we increase it, like increase the Vmax, increasing efficacy, all are like synonymous, and this are related to potency. Efficacious drugs have higher or low potency. So potency relates to the amount of the drug to produce this effect. Some drugs will not gonna produce like the maximum effect anyway. If you give like a kilogram of that drug, it is just not gonna produce the maximum effect. The amount that we give is like how potency, but the maximum effect is like how efficacy. So if the drug can produce like Vmax, it means like efficacious, whether it takes like 1 milligram or 1 kilogram to produce that. For example, partial agonists have less efficacy. It's like partial agonists from their name, they will not never gonna produce like the Vmax. Yeah. So they are like partial agonists. It's gonna be less. So on the other hand, like uh, so this is for efficacy. This drug A, for example, the red one is like efficacious versus drug B, where the Vmax is lower, is less in efficacy than the drug A. Potency, on the other hand, is like amount of the drug. So if you like look here, like the both of the drugs is gonna produce the maximum effect, so they have the same efficacy. But one drug is gonna produce like the maximum effect starting here at a lower dose. So this is like the dose. This is a drug dose at a lower dose than this drug. So this drug produce the effect at a higher dose. So this means like drug A is more potent than drug B. So it produces the same effect as drug B, so it has like the same efficacy, but it produces the effect starting at a lower dose than drug B. So this means like it is more potent. So the amount of the drug needed for a given effect represented by the X value, left shifting. So this drug A being driven to the left means like left shifting, decreased E C50 and increasing potency, or in the other hand, the other name, decreasing the drug needed. And this is something unrelated to efficacy. Both of the drugs can have a high or low efficacy. So thank you guys, and I hope you enjoyed our video or our episode today. Hope to see you later. Thank you.